Good afternoon, dear participants, and a very warm welcome to our fifth talk show, Let's Talk Primary Healthcare. My name is Melita Jakob, and I'm the head of the WHO European Center for Primary Healthcare. Thank you for joining us this afternoon. Our talk show series is drawing a sizable audience of over 200 participants from over 40 countries each time, and we are very excited that you continue to want to talk about primary healthcare policy during the pandemic. In our previous talk shows, we have looked at transformation at primary healthcare level during the pandemic. We have looked at priority setting and demand management strategies in face of increasing demand. We looked at population health management tools to identify those in greatest need. And finally, we discussed how better support the health and well-being of our primary healthcare workforce. Today, we will be talking about the role of primary healthcare caring for those who experience post-COVID-19 conditions. During the past year, we tracked the pandemic through data on cases and deaths. But now we understand that these only show a partial picture. There are people who continue to struggle to recover from acute infection, and they continue to experience often debilitating symptoms, possibly over a long time period. But what do we really know about post-COVID-19 conditions? What do we know about its manifestations? Who in the health system is best positioned to respond to them? What role for primary healthcare? What matters to people who experience these conditions, and how to take into account their views as we design services? These questions will be in the focus of our discussion today. We will be starting with a 1-hour panel discussion, which will be followed by 2 breakout sessions in English and Russian to listen to your experiences, how you in your countries are responding to post-COVID-19 conditions. In the meantime, come and join us in the chat, say hello to us, share your thoughts, share your comments. My colleagues will also be very actively using the chat, sharing useful resources with you as usual. And with that, let me welcome and introduce our panel. Hello to you all, and thank you for taking the time to join us today. And on our panel, we have Dr. Jamilia Abueva, who is director of Yanbekshi Kazakh Multidisciplinary Hospital in Kazakhstan. Jamilia will be speaking in Russian on the panel, so it's very important to those of you who are English speakers that you choose the language ribbon on the bottom of your screen and choose the appropriate language. Dr. Alphonse Olde-Luhuis, who is a general practitioner, head of C-Support, and staff member of the Radboud University Medical Center GP training in the Netherlands. Welcome, Alphonse. Dr. Nisreen Alwan, associate professor of public health at the University of Southampton, and Dr. Dina Pfeiffer, medical officer at the Health Emergency Program of the WHO Regional Office for Europe. Thank you so much for joining us today to talk about this very important topic. And let's jump into it. And let's start our first round of conversation by scanning the horizon. What do we really know and do not know about the post-COVID-19 conditions? And Nisreen, I'd like to start with you. You have experienced post-COVID-19 conditions yourself, and you have connected with many others experiencing long-term problems. What are some of the lessons you would like to share with those who design health services?
Thank you so much for having me. And I started this journey when I got the COVID-19 symptoms back in March 2020, so 14 months ago. And then I was one of these people who really didn't have, I didn't have a high risk profile to get a severe outcome from COVID-19. So I expected it, and the messaging at the time was it's like the worst it would be a short flu-like illness, and then you would recover. But I didn't experience that, because these symptoms, although they weren't severe at all, my symptoms that I didn't require to go to hospital at the time, they just didn't completely resolve, and they kept coming back, and it was quite worrying. But what reassured me a bit at the time that there were other people mainly posting on social media. Obviously, we were locked down at the time in the UK, and that was kind of our window to the world, what people were posting on social media, because there was nothing about this in the kind of formal media channels. And people were posting similar patterns of the symptoms not completely going away, having a kind of a fluctuating nature. And affecting their daily lives, their daily activities, the way, whether, they can do physical activity or mental activity. So I started talking about this from public health point of view. And I suppose that's where the first lesson comes is, particularly people of the first wave, we were almost not believing ourselves, let alone, others believing us, because the narrative completely didn't have that outcome at the time, that some people might get the infection and not be severe enough to go to hospital or die or go get admitted to ICU, but they could suffer for quite a significant amount of time. So I think that's the first lesson. I think it's people with long COVID, and actually even up until now, I think it's much easier now. It's much more known now, but it's still, I think there's a lot of uncertainty that people feel about what they're experiencing, and the surroundings, other people listening to them is really, really important. And that's where the power of the patient-led movement came, because there was that peer support of people experiencing similar course of the illness, sharing that experience, which actually the medical community didn't necessarily have, and didn't have that knowledge to kind of reassure people or do anything about it at the time. So I think that's, in terms of the lessons, in terms of people designing healthcare and designing and delivering healthcare, that is definitely the first lesson, is listening and believing people, because there's just an awful lot because there's still little knowledge about exactly what's going on in this post-COVID conditions or long COVID. Then there's still a lot of dismissal, or attributing what people are experiencing to different reasons, really not based on any solid evidence. So I think listening, believing, and trusting people about their own experience. People are just describing their own experiencing, their lived experience. So it's about that. And I think with that comes acknowledgement that there's little we know. I think the knowledge bit is tricky, because obviously it's not a complete surprise that some viruses produce prolonged illness after infection. We know that from many other viruses in the past, and particularly even from SARS, for example, a similar virus. But I think also there's a level of, we don't know, this virus is different. It's not exactly similar to previous viruses, as we know. So there is little knowledge about the course of the illness, the prognosis, what to do about it. And I think there needs to be an acknowledgement from healthcare service providers and people who design and commission health services that we're still there and we're developing that. So meanwhile, we need to listen and understand the illness a bit better. And I think there needs to be an acknowledgement, even from people in the health service, that this is because of the pandemic and what we've been through. This is not just a purely medical issue. This is a wide political, social, economic issue. And actually, these very wide things are affecting people's life. People who are coming, and having, saying, they've got these symptoms, they've got long COVID. There are all these factors affecting their lives as well. And there's still an awful lot of stigma in terms of, not recovering. You're expected to recover. You're not supposed to have this, but you have it. And that's really affecting the way you do your daily activity, your work, your caring for other people. And it's really affecting your mental health as well, and causing you distress and and this is not because this condition is in isolation. It's in a context of a pandemic as well. So there's all the pressures of the pandemic. And the narratives around it. And I think there needs to be this, there is a complex context that needs to be acknowledged around that. And then obviously from healthcare providers, it's very important, although we don't know exactly what the treatment of long COVID is, it's important to look at the specific symptoms people have and have proper physical examination and medical investigations to rule out any treatable pathology, something that could be treated, something we know about, underlying things such as blood clots, for example, that we know have people with post-COVID have higher risk of. So they need that thorough investigation rather than it being attributed straight away to, well, it's long COVID and we don't know exactly what to do with it. So yeah, I mean, I can go on, but we'll have time to go on about this, so I'll stop now.
Indeed. No, yeah. Thank you, Nisreen. I think that's really a great start to think about people-centered service delivery design from that angle. And Dina, let me come to you now. What is our state of knowledge about post-COVID-19 conditions, diagnostics, and management? And what does this imply for service delivery design and guideline development?
Perhaps we can show one illustration to remind ourselves what has happened in the past when we had a completely unknown entity. And many years ago, we were facing at the beginning of the 1980s, the problem of HIV/AIDS. And when we look to, well, let's call it the little bush to the left side of this illustration, then you very quickly see that it took almost 8 years before we got guidelines for management of opportunistic infections caused or associated with HIV infection. But it actually took almost 20 years to come up with an appropriate clinical management guidelines for AIDS patients. It's a very long period of time. Now, the huge tree on the right side of this illustration is very much making the point that we've done a long way through. We had numerous updates of COVID guidelines. We've done a lot in terms of diagnosing COVID, having harmonized tools to do these things. But there is still a very long way to go with post-COVID. And this is to say that we can accelerate the process of our understanding, and yet this homework needs to be done. Now, we know that the typical recovery post-COVID is about 2 to 6 weeks, but some people do have persistent, new, or changing symptoms that occur after that period or during this period when they are not infectious anymore. This is not the case of a chronic infection like hepatitis C, but there is quite a lot of sequelae, and we don't fully understand it because COVID in itself is an inflammation of endothelium. So it can hit any of the organ systems, and the sort of the mix of the symptoms and problems that an individual have can be quite unique. And it's usually not just one, it's a mix that they take, and they do require a follow-up. So it's quite important that regardless of their diagnosis, whether the COVID was confirmed or suspected or maybe completely asymptomatic, they should receive a proper follow-up and have access to the clinical care for the period that would be required. But how much do we know? Well, we know, fortunately, a little. We have a lot of theories that we can sort of take to our help. So it could be virus-specific pathophysiological changes that we are seeing in post-COVID. It could be immunological aberrations and inflammatory damage in the response to acute infection. But it could also be expected sequelae of critical illness, like the post-intensive care syndrome, which certainly some of the patients that have required critical care may be suffering from. So post-COVID is a mixture of some entities that we know a little bit more about, but also quite a lot we don't know about. And this is why it's important to be open-minded and take this challenge with a good dose of research into our regular clinical practice. I know the frontline workers say this is for somebody else, but the reality is we can't treat our patients and we can't diagnose them if we don't tie this up with some sort of monitoring path that generates evidence and tells us how to proceed. So we know some things, but there is a lot more that we need to generate to be able to design adequate interventions.
Thank you, Dina. I think that's a great start to talk in a moment about how we can deliver services in the face of this uncertainty. But before we go there, Nesreen, let me come back to you and let me ask you to wear your public health hat. What do we know about the epidemiology of the post-COVID-19 conditions and the numbers we are seeing at country and regional level?
Yes, thank you so much. So yeah, with the public health hat, I suppose the challenge that we've had up until recently is that our systems, public health systems in most parts of the world weren't really set up to monitor or track morbidity from COVID-19. They were set up to track infections, so to look at spread and community infection and mortality and hospital admission, so that not to overload the hospital. The morbidity we're talking about, particularly for those non-hospitalized patients, weren't tracked at all. So we then had some studies, relatively smaller scale studies, which vary a lot in terms of the prevalence figures they give us. But mostly they were quite concerning, and mostly they were over 1 in 10 people who infected with COVID will have some prolonged illness for many weeks. More recently, one of the I think more reliable studies were the study done by the Office of National Statistics in the UK, where they had a COVID infection survey, a regular infection survey. So it's a random sample of the population where they are screened for infection over every week for the past year or so, and they followed up people in that survey, and it turns out that people, the prevalence was overall was about 14% of people who would have at least one persistent symptoms after 12 weeks of the infection, and much higher, about a quarter, at 5 weeks. And that varies a bit by age, but it seems to be quite, maybe the higher is kind of the younger adult age groups, but also more concerningly present in children. So about 7 to 8% of children who would have that. They also asked people. So these are the estimate based on follow-up of lab confirmed COVID from their study, but also they asked people about self-reported COVID, because as we know, in the start of the pandemic, most people weren't admitted to hospital, and many countries, including the UK, were not tested, so they did not have the lab confirmation. And they actually estimated that based on that, whether people think they've got long COVID, is about 1.1 million just in the UK living in private household, and with some groups much higher. I mean, some of the startling figures were, for example, healthcare workers. Around 3.6% of the healthcare worker force in the UK, think they have long COVID. So that's quite big figure. So I think it's relatively common. Now the severity is varied. So whether it affects your daily life significantly or slightly, or it doesn't, it varies. But a big proportion of people also say that this affects their daily activities significantly, leading to kind of disability and effect on activities. Indeed. So it's a common outcome, but I think from a public health point of view, and that's what got me involved in this mainly in the first place, is that we're not measuring this well. And I think I'd like to pick up the point about the interaction between care and research that was made earlier, because I think we in this context we're in, we have to do that. The access to services has to be somehow counted well, so that we know what the size of the problem each country is dealing with, I suppose. Yeah.
Indeed, and that's actually the perfect segue to now look at how we can deliver services for people experiencing these conditions. And we have two very interesting country examples from the Netherlands and Kazakhstan. Alphonse, let me bring you in first. You are leading and delivering frontline health services. How do you organize services for those experiencing post-COVID-19 conditions? Who is best positioned to provide these services, and what lessons are emerging?
Thank you. Thank you for the opportunity. I was always a GP in a small village in Holland, so my English is not as average, but I will do my best. And I was by the Q fever outbreak, what was in my village. I came to the importance of post-infectious sequela. The post-COVID care in our country, in the Netherlands, is divided in two groups. A small group that is hospitalized, that are the people that went to the intensive care, that were male mostly, and old people. And they are followed by specialists. It's a small group, and they are going to rehabilitation in rehabilitation settings, clinics. The other group, the majority group, are the patients who were not admitted at the hospital, who had an illness at home, living between bed and toilet. It's very important to follow the journey of those patients, not the journey in diagnostics, but journey in how they were before, what happened to them, and what happened in the months following. That's the most important. And those healthy people were very sporty, most female, many of them health workers, doctors, GPs, and they became a shadow of themselves. And it's important to follow it in the biological, in the psychological, and in the social dimensions. That's my most important sentence, that they were attacked by a system attack by the COVID virus, and that gives lung, heart, but also very important, the brain problems, the microglia, and that gives fatigue, pain, palpitations, sleep, smell, headache, cognitive dysfunction, anxiety. And in the social dimension, it gives that there are other people at home, that they lose work, employment, and the best to follow that is the primary care. It's not only because I was always a primary care, a GP, but it's really the primary care. And in Holland, we have a very good primary care, and as most of you know, with good paramedic rehabilitation and psychological support in our centers. And that was very strong. But this system was, even in the start of the pandemic, really overloaded. GPs get ill. There was no place in hospitals, and they losing their guiding role. And patient went to hospital for one stop, or went to the physic trainer for one stop, and then get extremely tired back. And so the doctors weren't able to rise the problem. That's the time that we started the Dutch initiative, and it's called C-Support, Corona Support. It's initiated by the Dutch government, and we have a strong multidisciplinary approach, a strong team with a lot of social workers, nurses. They are very special trained for all those post-infectious sequela and help people over all those dimensions. We, C-Sport, follow the academic trials, so hands-on patient care without taking the care over, a lot of attention for research or address for research for the post-COVID, and also very important, education of patients, and also for healthcare workers in all layers, paramedic, specialists, and GPs and physicians. That is the most important. What are we doing? We connect. So the paramedic, the physical gives a lot of training, but often too much, and in combination with psychological and an occupational team, they can do it is pacing, making it a little bit slower, better. The doctors, the GPs, we train about the sequela and also how to connect with the occupational physicians, because they can together follow the line of the journey of those patients. Why? And it works. Already now there is rest. There are guidelines for multidisciplinary approach, and people are more happy in their role. Why multidisciplinary? COVID clearly does not restrict only to the lungs. That's in fact my answer. You have to be multidisciplinary. And I there was in the Lancet an article that someone that knows everything about COVID, you should distrust, because nobody knows everything about COVID. You have to be modest in it. And what are the lessons so far? And that's 3 lessons. That is, a single stop doesn't, for a specialist, does not have many attributes in care. It makes even a little bit worse. It's a dynamic disease, and you should test it with functional impairment, and it needs a special kind of diagnostic. And the second one is also an important one. In our group, and we have already more than 5,000 people that have more than a year severe problems. We miss in our cohort the elderly, the people with lower CES, and the immigrants. And that's really also an item I want to be frankly about.
Thank you very much. I think those are very powerful points, and many of the points you raised resonates with Dina's narrative about the importance to learning from what we're doing and constantly feeding back to improvement of our guidelines. And also Nasrin's description of the post-COVID-19 conditions, how patients' experiences and what that implies for service delivery design. Let's now go to the other end of our region, to Kazakhstan. Jamilia, let me bring you in. You're managing a very large population area, a combined primary healthcare hospital delivery system. And your area covers also a very large rural area. How are you caring for post-COVID-19 conditions?
Здравствуйте, уважаемые коллеги. Спасибо за предоставленную возможность поделиться своим опытом работы медицинской организации, которая в своем составе имеет действительно и больничную систему, и систему ПМСП. Я совершенно согласна, наверное, опыт работы и вот прошлого, и этого года с ковидом. Вот Альфонс сказал, это действительно это часть пациентов, которая прошла через тяжелую оказание помощи, это больничная, стационарная помощь, и большая часть, 2/3, это те, которые переболели, перенесли это в условиях амбулаторные, самостоятельным каким-то лечением, не всегда обращаясь к врачам, но и обращаясь тоже. И вот на сегодняшний день, уже вот в течение, уже после года мы имеем вот эти осложнения, вот это постковидное состояние у наших пациентов, и мы теперь живем в ПМСП с большей частью, с проявлениями вот этих постковидных осложнений. Наша организация уже 3 года как работает по принципу, такой командный, мультидисциплинарный принцип семейной команды. Это участковый врач, медицинские сестры, обязательно социальный работник и психолог. И вот этот мультидисциплинарный подход, вот такая уже сформированная команда, она дала нам удивительно вот в этом году, в течение этого года и вот сейчас в постковидном периоде возможность близкого контакта, оказания помощи пациентам, именно используя все возможные ресурсы, и в первую очередь это вот помощь семейной команды, это социальных работников, психологов, медицинских сестер, и уже эта связь, социальные работники у нас в данном случае, это именно члены этой команды, на сегодняшний день являются первым звеном, которое слышит пациентов, которые перенесли COVID, жалобы этих пациентов, их какие-то потребности на сегодняшний день. Они явились у нас на сегодняшний день коммуникаторами между вот с теми пациентами, которые находятся дома, которые самостоятельно в какой-то момент выходят из состояния постковида, коммуникаторами для оказания вот этой первичной помощи им, помощи в направлении по самореабилитации, помощи в направлении к специалисту, к семейному врачу. И, конечно, учитывая вот многие осложнения, в первую очередь неврологические, психологические, такие социально-психологические последствия постковидные, необходимы консультации психологов. Медицинские работники, социальные работники, они у нас находятся как раз-таки ближе к уязвимым людям, к семье. Мы пошли таким путем уже сами, что мы предоставили социальным работникам такую простую анкету основных симптомов постковидных симптомов, благодаря которым, опрашивая это население, опрашивая наших пациентов, они формируют необходимые потребности у этих пациентов. Или это реабилитация, если это не осложненные какая-то симптоматика, то это самореабилитация на дому, амбулаторно. Если это более сложные осложнения, то консультация психолога. Они своевременно могут услышать их потребности, направить их к участковому врачу, к семейному врачу, направить далее, может быть, к узким специалистам. Но вот это тот путь, который мы сейчас проходим, идем, двигаемся, и то, чему мы учимся. Мы действительно, как сказал Альфонс, мало что знаем еще об этом заболевании, об этих постковидных осложнениях.
Thank you very much. Yes, thank you very much, Jamilia. I think that's very interesting and very much resonates with the message of Alphonse that primary healthcare is very well positioned to provide these services, but it has to be a multidisciplinary approach. And in both of your narratives, and in fact earlier, it's becoming quite clear that we need to focus not only on the biomedical aspects, but also on the mental health aspects and the psychological or the social aspects of these conditions. These are exactly what matter for the quality of life of people. So Alphonse, can I come back to you for a quick comeback? You mentioned the role of mental health workers and in particular occupational health specialists in your teams. What is their function exactly? What is it that they do to help support these patients?
The psychologist is important. You have to think about young, strong, almost invincible people that fell down, and they want to try harder than it's possible. That's the most important issue. Yesterday I spoke to a professor of rehabilitation, and he said 99% of those people post-COVID want to go too fast. And to learn that, you need psychologic. We use ACT, acceptance and commitment therapy, and we use that also with occupational health to learn those GPs in working in occupational health physicians to learn how to pace. That's most important, and it's the only thing that works and makes patients also feel support.
Jamilia, let me come to you with the same question. You also mentioned the role of mental health specialists, right? And social workers on your teams. How do they engage with patients? And more importantly, how do you support them as a manager and service designer to better engage with patients? Do you have some sort of guidelines or ways to guide them, algorithms to help diagnose people?
Спасибо за возможность сказать. У нас протоколы диагностики, лечения и ведения таких пациентов уже определены в Казахстане, они есть четко разработанные. И вот на сегодняшний день уже готовится руководство по постковидному ведению, реабилитации таких пациентов. Но мы на своем уровне именно здесь вот помощь ПМСП, и считаем, что чаще нужны не столь сложные реабилитационные мероприятия. Те пациенты, которые сидят дома, не всегда им нужно обязательно сложные стационарные лечения или какие-то мероприятия. А именно это обучение самореабилитации, которое пациенты могут применять дома. Значит, а для этого как раз-таки эту информацию, как применять эту самореабилитацию на дому. И лучше всего именно мы помогаем, что социальные работники, медицинские сестры помогают им делятся ими этой информацией. Мы, используя вот эту анкету по признакам, которые жалобы, которые основные жалобы, нарушение ментального здоровья, нарушение психологического здоровья, даже вот это несогласие с тем, что пациент сам не может быстро выздороветь, он не может не всегда понять, что же происходит, что он не может вернуться в обычную свою среду, к своей работе, к своей обычной жизни, помочь ему с этими вопросами. И вот опросив пациента, накопив какой-то процент вопросов, мы уже знаем, и социальные работники, и медсестры знают, куда и в каком направлении направить маршрут пациента и как ему помочь.
Very good. So Nesreen, let me come back to you. We heard from two country experiences how services are being designed. We heard a case made for a very strong primary healthcare-based multidisciplinary approach because patients with post-COVID-19 conditions require holistic care rather than a very specialized one. How does this resonate with you?
Yeah, so I think multidisciplinary absolutely needed, and it's the case been made very, very strongly here, and I support it. And the case for addressing inequalities, when we've got this condition where we don't have standardized training, guidelines, pathways of care, that there is a big potential for widening inequalities that, and people who are less listened to, maybe less believed, certain population groups. We've seen, particularly in long COVID, women, people from ethnic minorities, Alphonse mentioned immigrants. I think people who, the wider inequalities we see in access to health service apply more acutely to long COVID. And I think it's very essential, I won't be long, but it's essential in any service design to listen to the patient and involve the patient in service design because they're experiencing the condition, and a wide range of patients as well. So, going to these less heard groups of the population, asking them what they need and what would help them access and utilize the services, because a big problem is people sometimes give up. They don't even access the services because the service is not responding to their needs.
Very good. And I think that also leads us now to come to you, Dina, and think a little bit about the connection to specialist care. And I think Alphonse used the term one-stop shop for COVID diagnostics. Could you unpack for us what this term means? And what do we think about pathways to specialist care, and what is the role of primary healthcare in managing and organizing that pathway?
Thank you for the question. Of course, the one-stop approach may mean different things in different health systems. But essentially, if we do take a patient-centered angle, what it should mean is that it becomes its services with the least effort to access them in a comprehensive way, which is repeated along so we can monitor the change of the status of this patient. But because our patients can have a very variable set of symptoms and require different specialities, this knowledge about the findings or the progress needs to be somehow put together so that we don't have a fragmented approach. Now, this may mean that there is a team that monitors specific patients at one location. This can be that the primary healthcare service has the function of getting all of these inputs from different specialities and taking it forward and managing it. But it also has a different perspective, more from a clinical research angle or from a health system angle. If we take the figure that about 10% of our patients will have some form and severity of post-COVID, with currently over 150 million confirmed cases of COVID, and who knows how many who have not been diagnosed, this is a huge population. And if we take some of the most frequent symptoms like muscle pain, inability to have physical activity or mental health issues, it very quickly transpires that our mental health specialists or a rehabilitation specialist, a rheumatologist, might be predominantly seeing these patients from today into the future, completely forgetting of all other patients that they would have normally seen and cared for. So clearly, one-stop approach ensures that COVID patients get a comprehensive, holistic approach, but on the other hand side, that we make sure that the health resources are sufficient for maintenance of regular service with this addition that we are facing. But lastly, we don't know how to manage these patients. We need to understand this. There is a lot of cognitive bias in management of our patients by taking whatever interventions and not documenting them. So it's this research element is so important, and our post-COVID patients are very open to participate in these randomized or observational trials to generate the evidence, because it's only in this approach that we will come with sustainable and effective sort of treatment for our patients. Maybe to put it a little bit closer to your heart, there is a larger percentage of healthcare workers that got COVID, and quite a number of them, unfortunately, have post-COVID. And we would like to see them back in a service. So just think about that subset of patients, what it means from the occupational health perspective to really adequately and safely return them back to their service. And then you can extrapolate that to all professions that we have, or maybe it could be children or elderly or specific groups that has been mentioned. So when we say one-stop approach, it means it's a coordinated approach. It's coordinated for the patients, it's coordinated for generating evidence, and it's coordinated in a sense what different national systems can offer at this point in time. But it should be comprehensive, and it will certainly change over the time as we learn more.
And I think it would be very interesting to hear how our two countries, Kazakhstan and the Netherlands, ensure that specialist services are well coordinated and that patients don't get lost. Because I suppose that's our major worry, right? That if primary healthcare is not strong enough, if this multidisciplinary team doesn't exist, if there are no clear referral pathways, if there are no one-stop shop diagnostics, patients with various symptoms will begin to see specialists on their own in an uncoordinated manner. Jamilia, in Kazakhstan, what is the role of specialist care for post-COVID-19 patients, and how do you make sure patients don't get lost in the system?
Спасибо за предоставленную возможность. Значит, узкие специалисты. Конечно, здесь вот мы идем путем, что первая связь пациента с семьи – это вот социальный работник, медицинский работник, и уже от них он идет к участковому, к семейному участковому врачу, и после этого идет направление к узкому специалисту. И вот эту связь, потребность, не всегда даже такая нагрузка на врачей, на сотрудников ПМСП идет очень большая. Тем более сейчас вот постковидные заболевания, они еще идут, они занимаются больше лечебной деятельностью. А вот эти постковидные пациенты, они, вот здесь мы смогли обеспечить их связь через социальных работников. Мы сформировали так называемый ситуационный центр внутри нашей организации. Узнав о потребности пациента, все-таки необходимость есть по определенным признакам, что нужна консультация семейного врача, а далее консультация узкого специалиста. Это сообщается в ситуационный центр, пациент ставится на очередь на консультацию, и только после этого мы направляем и обеспечим его консультацию узкого специалиста. Конечно, потому что если это идет прямое обращение наших жителей к узким специалистам, нагрузка будет крайне большая. Благодаря такой технологии, через вот такой ситуационный внутренний центр мы смогли такой маршрут проложить более... С одной стороны, мы не теряем пациентов, которые остались один на один и которые в этом нуждаются в консультации узкого специалиста. И с другой стороны, мы смогли остановить поток самообращения. Это тоже работа прямая социального работника с человеком, у которого есть потребность с постковидными проблемами. Особенно это, конечно, большая часть неврологические и психологические потребности.
Thank you very much. Alphonse, let's come to you. How do you organize the connection to specialist services when it's needed? Alphonse, I don't know if you heard the question. We'd like to hear from you as well, how you in the Netherlands organize the link between your primary healthcare teams and specialist services to bring them in when needed.
In our country, the GPs have a strong role. They are, in fact, leading. Even if a patient is admitted to hospital, the GP stays in charge. That's a little bit different of many countries. But that is also our problem in the start of the pandemic, because we have very little beds, hospital beds in Holland. We have much lesser than the UK and Germany, our neighbors, and Belgium. That's why we had to go to Germany in the start of the pandemic. But about the specialists, I like the story of Dina, but in Holland, the specialists are a little bit annoyed and not so interested in the long COVID, because they cannot find it so much. And they even sometimes you hear believers and non-believers. They think that's a little bit burnout. And that's why we started now a new initiative in the academic centra in Holland to give a small selection of severe post-COVID patients, have a very dynamic research. So diagnostics with functional MRI of the brain, of the heart, of the diaphragm, and also metabolic, about embolism and so on. And that's I think it's a very good initiative that gives new insights also for all those other outpatients that cannot go to the hospital, because in my opinion, there is no need for most long COVID patients to go regularly to the hospital if they are treated well by the first line.
Thank you very much. And when conversations are good, time flies so rapidly. We're coming up to the last round of our discussion, and I'd like us to think together to the future. What can we all do better collectively to better care for people with post-COVID-19 conditions? What can governments do? What can those do who design coverage policies and services? What can healthcare providers do? What can we in international organizations do? And I will give you the floor for your closing remarks. What do you see as 1, 2, or maximum 3 top priorities and recommendations for the future? Let's start with you, Dina.
Thank you. Well, This is a novel situation. So novel situations, novel conditions generally require very often novel solutions. And clearly, I would like to call for an integrated in-service research approach. WHO has issued harmonized tools for data collection, but it's not really, it is about data collection for national decision-making, of course, but it's also that we monitor the patients in a consistent way and that we can characterize the disease, which will, of course, get us in a better situation, not only to monitor them, but to come with ideas how to manage them if there is a suitable intervention. The second thing I would like to mention is that not all of our patients will have diagnostically positive findings. We know that many of the findings require very specialized equipment, which is not generally available, which is only used for sort of very specific scientific research approach, where we can show the damage that the virus has done. Nevertheless, it doesn't mean that we have to deploy the high-end diagnostics for each and every of our patients. But we do have a monitoring framework and we deploy it for every patient, which is suitable for the system and for the system can deliver. And lastly, I would call for evidence-based decisions. So it's not like we pick up interventions and say, that's probably going to help, or this is maybe going to help. If we don't document, we will never know if it works. And we are all in the same boat. So we are building the boat as we are sailing, but this effort will need to be done. Everything else is losing time, losing our patients, and not really being faithful to the principles that we normally deploy in clinical management, not harming the patients and really trying to find sensible solutions.
Very powerful closing messages. Alphonse, how about you? What do you see as key priorities for the future?
First the COVID does not restrict only to one biological aspect. It's important, that makes me to the most important point for me, integrative and multidisciplinary approach with the patient is so important. And in fact, COVID gives us a chance to make certain systems in our healthcare have a new look and find better ways. In my opinion, organization like C-Support that doesn't take the management over, but makes connection is a very good instrument. Second is follow the journey of the patient is so important. And in that following the journey, let them also, if they want, participate in a trial about paramedic rehabilitation or work and income. And that's so important. And third is outbreaks like this ask for an adaptive and flexible approach of us healthcare professionals. And this requires a permanent training for this. And that's also my important issue.
Very good. Thank you very much for those thoughts. Jamilia, let's come to you now. What do you see as the top priorities for the future?
Спасибо. Однозначно соглашусь с Диной, с Альфонсом. Мультидисциплинарный подход, методические четкие рекомендации. Значит, обязательно, конечно, правила, четкие этапы реабилитации и маршрут пациентов. Маршрут пациентов, это все должно быть, конечно, отработано методически, одинаково, стандартизировано, чтобы каждый пациент, который перенес с постковидным синдромом, мог быть охвачен. И это в первую очередь, конечно, нагрузки работы именно для ПМСП. Вот. Нам очень крайне важно обучение. Обучение как медицинских работников, именно ведению, выявлению, введению, так и обучение самих пациентов по самореабилитации. Наверное, вот это вот самое главное.
Indeed, those are very important priorities. Nisreen, we started with your voice. Let's close the panel with your voice again.
Thank you. Great messages made before me. I'd like to maybe from a public health point of view mention at the end, this is not over. It's not that people had long COVID and it's finished and we have to only care for those who had it. This is an ongoing problem. We need to prevent more long COVID. It's still happening. And the messaging from a governmental point of view, public policy point of view, is that infection risk is not just acute. Infection risk is chronic. This could mean months and years, massive effects on society and productivity and the workforce and everything. The message needs to change in terms of how we deal, with the pandemic and how we respond to the pandemic, because it's still ongoing. And I think the same message to primary care. I think primary care and all of the health services really deal better with the acute side of medicine than the chronic. And maybe there's a silver lining here for this pandemic to say, look, viruses have these morbidity, lots of morbidity attached to them as well, or infections, and we need to plan for it properly and address it properly, not only very much focus on the acute side of infections and pandemics, because we're likely to have future pandemic and we have epidemics all the time. So really it's the balance of the acute versus the chronic. There's just, chronic tends to be sometimes there's more inequality in it, and there's more, less focus on the pathways of how to, for people to care for people. But actually, it has a massive effect on society. Thanks.
Thank you very much. I have learned so much during this conversation today, and I think the points that are emerging as takeaway messages is first, that we have to recognize that post-COVID-19 conditions exist. We have to recognize them clinically and push forward with the generation of guidelines, but also from a public health perspective, to be able to measure it and estimate the impact and the implications for our health systems and the already overstretched health workers. And thirdly, in terms of government messaging, as Nisreen just said, we have to recognize its existence and adjust our messaging accordingly. The second important message I learned in this conversation today is that the nature of these conditions and their manifestations require a holistic approach, and not just the biological aspects, but really the mental health and the social sequelae of the post-COVID-19 conditions are very important. And because of this reason, primary healthcare is the best positioned to give this holistic approach and a patient-centered approach, but only if there are multidisciplinary teams in place that can handle this workload. We need to take into account people's voice in the service delivery design, in particular because our knowledge is still emerging and our understanding is still emerging. We need to move forward with standardization of practices. And finally, as many of you emphasized, we need to engage in practice-based research to continuously evaluate what we do and translate it into better guidance to those who work at the front line. With this, I would really like to thank our panel. Thank you very much for your insights. Thank you very much for sharing your professional, but also your personal experience. This has been a very rich discussion. And now we would like to hear from you. What has your country been doing to respond to the needs of post-COVID-19 patients? We invite you to 2 breakout sessions, one in English, the other one in Russian. My colleagues are posting the link to the breakout sessions into the chat window. Please click on those links, and this main window will automatically close. My colleagues will stay online here to help you. If you have any problems, please write some notes in the chat, and we will try to help you. When you close the main window, a pop-up window will bring a survey to you, both in English and Russian languages. This survey is very important to us. We look at it very carefully. It's very, very short, but we look at it very carefully to shape how we're doing in our talk shows and to choose topics that you're interested in hearing about. So please take your time and fill it out. And with that, I say goodbye for now. I see you in the breakout sessions very soon. Thank you and goodbye.